Are we starting?
Yes, we're starting. So in the last 2 hours, I've managed to cover 36 out of 138 slides. I have got to go faster, right? But I have so much fun going so slow. I'm like, oh, we'll get to it, whatever. I apologize to the peds nurses in the group because they would get cheated. One of these days I'm going to start with peds and then, no, I can't do it. All right, so let's get started talking about multifetal pregnancy, also known as twins, triplets, quads, that kind of thing. Okay, so there are two basic categories of twins, or of multiples. There's the monozygotic and the dizygotic, okay? Mono meaning one zygote, dizygotic meaning two zygotes, okay? So the difference obviously is between how many zygotes do you have, okay? And that's how early in the pregnancy do they split, okay? So the monozygotic twins are identical twins. Egg and sperm unites, they split into two, and instead of splitting into four, they become two totally different cells, and then they start their process, okay? And so they start from the same zygote. One egg, one sperm, accidentally makes two babies instead of one baby, okay? The earlier in the split, the more differentiated they are. Okay, I'm sorry, the more similar they are. So if you, I'm sorry, that's the other way around. The more differentiated they are. So if they split in the first 72 hours, you end up with your, I'm sorry, I put di here. It's mo-di twins. Okay, what that means? No, di twins. Yeah, di twins. I'm sorry. So the concept is you have the placenta and the amniotic sac, okay? When we talk about mo-di, di, we're talking about one of them represents the placenta, one of them represents the amniotic sac, okay? So a mo twin is monoamniotic, monochorionic, okay? So that means there is one placenta, one amniotic sac, and they both live in the same sac, okay? My favorite analogy for this, someone taught it to me this way, and I've always loved it ever since. Imagine you got a pair of roommates, okay? Now there are different living arrangements for roommates. You can have two people who live in the same room, and they share the same kitchen, okay? Those are mo twins, okay? They have one room and one kitchen, one placenta, one amniotic sac. Then there are mo-di twins. Mo-di twins, they live in the same room, but they have two separate kitchens. Okay, so it's like one on either side of the house. Okay, that's a mo-di twin. And then there's the di twins. It's two people who live in the same apartment, but they each have their own bedroom and they each have their own kitchen. Okay, and so what differentiates when they're going to become di twin, mo-di twin, mo twin, conjoined twin is how late did that zygote break into two different beings. Okay, if it happened very, very early, they're going to be di. They're going to be two totally different pregnancies that happen to live next to each other in the same uterus. Okay? But if it happens between 4 and 8 days after conception, they become mo-di twins. If it happens more than 8 days after, but before the differentiation of the amnion, they become mo twins. And if it's after differentiation of the amnion, they become conjoined twins. Joined at the head, joined at the chest, joined at the wherever. Okay? They are so close together that they're pretty much the same person with two separate brains. Okay? So, so that's the monozygotic or identical twin. Okay? Now, as far as risk factor goes, which do you think is the most dangerous? A di twin or a mo twin? Which one? The mo. Exactly. The mo twin is the most dangerous. Why? They share everything, exactly. There's one placenta that they have to share, not two placentas that are side by side. And most dangerous, there's nothing separating their umbilical cords. And the umbilical cords get tangled into a knot all the time. And mo twins develop well until one of them gets a knot in their cord that's too tight, and they end up, one or both of them will die in utero, okay? Usually like 26 to 40 weeks. Mo twins never are allowed to go to term if we know they're mo twins. We want to deliver, we watch it extremely carefully from like 28 weeks on. And we usually will induce labor at like 34 or 35 weeks to get them out. Now, luckily for us, we don't usually have to make that choice because Momo twins almost always have twin-twin transfusion syndrome, where one twin gets too much resources and the other gets not enough. Both of them are in trouble. Okay? Yes?
Could you repeat the analogy about the apartment?
Sure. So imagine twins are people sharing the same apartment. Okay? A die-die twin has 2 separate bedrooms, 2 separate kitchens. They're really just 2 people who live in the same apartment building. Okay? They're very, very different. They're separated from each other. Mo-die twins live in the same room, but they have 2 kitchens, 2 placentas. Okay? But they're in the same amniotic sac. I'm sorry?
Mo-die.
Mo-die twins. I'm sorry, I mixed it up. They have 2 different rooms and 1 kitchen.
Oh,
So
okay.
I messed it up. I'm sorry. It's 2 different rooms and 1 kitchen. Okay.
And the kitchen
So
is-
there's a line between them. They're not in. They're in their own amniotic sac. So they're not touching each other, but they share the same placenta.
Okay.
Okay. And then a Momo are in the same sac and have the same placenta. Okay. Anytime you have 2 or more babies on the same placenta, you have a problem with how they share resources. Okay. There is almost always, well, they're not almost always. There is always a sharing that is unequal. Okay, between the 2 twins, okay? And you have a small twin and a large twin. One baby doesn't get enough blood supply, and he is very premature. He's very growth restricted, and he tends to be, he just doesn't develop properly. However, he is the stronger of the 2 twins, because he's had to fight for survival his whole life. The other one gets polycythemia. He's much larger, lots of resources, a big old fat kid. But he's weak, okay? Because he's never had to struggle to survive. The bigger twin is the one in most danger on the outside, okay? Now, in utero, the small twin is in danger, okay? Because he's starving to death. But he's a scrappy little guy, right? But on the outside, he's fine because he's always been taking care of himself, okay? And even though that's a real kind of crude analogy, come on, it really does make sense. It really does happen that way, okay? That the smaller twin does better on the outside, and the bigger twin has more problems on the outside. Yes, ma'am?
Okay, I don't know if I'm just writing this down wrong, or am I hearing you?
I made a mistake the first time, so I'll say it again.
Okay, so Momo is same placenta, same amniotic sac.
Exactly.
Mo-die is same placenta, different amniotic sac.
Exactly.
And then die-die is different placenta, different amniotic sac.
Exactly.
Okay, just make sure I had it right.
So die-die would be
Die-die is the
fraternal
safest.
twins.
No, they're still identical,
Oh,
okay? They're still identical, but they're totally differentiated from each other.
okay.
The dizygotic, those are the fraternal twins, the non-identicals, okay? And identical twins, all of the monozygotic pregnancies are a result of an accident at the time of conception, okay? Where they should have been 1 baby, but they formed 2 babies accidentally, okay? Now the fraternal twins, the dizygotic, 2 sperm, 2 separate eggs, okay? That's, those, and the dizygotic are the ones that run in the family. If your mother had twins, non-identical twins, you're more likely to have non-identical twins because your mother's ovaries and your daughter's ovaries work too good. They release 2 eggs instead of 1 every month, or 3 eggs instead of 1 every month.
Twins
Okay?
don't skip a generation, like they say?
No.
Wow.
I mean, they can because you're talking, recessive versus dominant, which genetic is turned on and which isn't. But the reality is you're just at higher risk of it. Okay? So someone had a friend who was very young, got twins, and then like a year later got twins again. That person, I would definitely say, watch your daughters because they'll make twins. Okay? Because they're really likely to fire off more than 1 egg. Okay? So that's the dizygotic twins. Okay? Now,
They had all boys.
understand when they had all boys? Thank God. So, understand when we talk about the placentas, okay? And we call it 2 placentas, all right? When you look at it, it looks like 1 placenta. It's not like they're in 2 different locations. They are 1 placenta, but there is a very clear membrane between the 2. So they grow side by side, but they really are 2 separate placentas, okay? And it's that membrane between the 2 of them that decreases the risk of that twin-twin transfusion syndrome. When it's 1 placenta without the separating membrane, they are literally sharing the same blood supply, okay? And there's this concept called AV nicking, where the blood vessel breaks and it favors one versus the other. And you can actually, there's actually a few doctors who go inside with a camera and a laser and will burn the various blood vessels to decrease blood flow to one, and that enhances blood flow to the other. It's a pretty fascinating thing. But that's way down there. But anyway, so that's the difference between, that's how you get twins. Either an accident when egg and sperm united and started to separate, that they accidentally formed two separate babies instead of just one, or that two eggs met two sperms at the same time. Okay. All right, minimizing threats to babies, your big deal. What you need to know when we're talking about minimizing threats is evaluating the environment and the lifestyle of the pregnant woman, okay? If she's in an abusive relationship, if she's smoking crack, if she rides without seatbelts, if she's exposing herself and her baby to cigarette smoke, all of those things are the environmental and lifestyle choices. We don't recommend going on roller coasters or jumping out of airplanes or any of that fancy stuff while you're pregnant. So those are the environmental lifestyle choices we want to talk about. Take it easy. You know, I don't recommend horseback riding unless you always ride horses. I don't recommend skiing, downhill skiing, but scuba diving, but snowboarding is way out of the question, but cross-country skiing is okay. What I usually tell people is no rugby, no football, no jumping out of airplane, no downhill skiing, and no scuba diving. Those 5 things are very, very bad for baby, okay? Cross-country is okay, snorkeling is fine, but otherwise, anything where you're likely to fall or get hurt, you definitely don't want to do it. And scuba is bad for baby because you breathe nitrogen instead of oxygen, and so nitrogen causes IUGR, which is why snorkeling is okay. And then evaluating their knowledge base. My wife, who's had 8 children, who is an RN herself, you don't need to tell her anything. She's got it, okay? But the 17-year-old first-time mom who doesn't even know how to balance a checkbook or drive a car, she needs more education. Okay, and so figuring out their knowledge base to begin with, and where they are psychosocially and physically in their development. You know, we talk a little bit about like adolescent pregnancies. They struggle with things because they're still children themselves, and they're not. So psychosocially they got a lot of to overcome. And you know, if they're being abused from their partner on a regular basis, they got a lot to overcome too. Okay. Preconception counseling, we wish everybody would do preconception counseling and no one ever does, okay? It's a total crapshoot. You know, we get pregnant, I don't know, I'm just throwing it to the wind. Let's see what sticks, okay? I don't know if I'm healthy or sick. I don't know if I have any genetic abnormalities. I don't know what my cousin died of at the age of 12. I don't know, screw it. Let's just see what happens, okay? That's how most people in America get pregnant. They have absolutely no concept of the risk going into the pregnancy, okay? They just do it because, well, getting pregnant is kind of what you're supposed to do. So we wish everybody would do preconception counseling 6 to 12 months before they got pregnant. So we could talk about what are your genetic risk factors, what runs in your family, what's in your environment, what could you clean up in your environment. Now's a great time to stop smoking, to start exercising, lose a little weight, get that diabetes under control, get your blood pressure well controlled before you get pregnant, that kind of stuff. And nurses can be very useful in that because we teach wellness. And so we try to achieve a state of wellness, then get knocked up. It is so much better. So much better. And if we could do that, we would really solve an awful lot of problems. One of the reasons that America has a higher mortality rate than others is because we can get anybody pregnant. We can get our diabetics pregnant. We can get our heart disease patients pregnant. We can get our PCOS patients pregnant. We can get all these people who should never get pregnant, okay? Because we got such, you know, such easy access to medications and stuff. Okay, back to teratogens, just a little bit for you. These are goods and bad. These are the bads. Okay, torch is bad. Toxoplasmosis, other viruses, rubella. What was the other? The C was cytomegalovirus and herpes. Bad, bad, bad. Okay, especially if you get them for the first time during the pregnancy. If you have herpes already, who cares? Just if you have a herpes lesion when you deliver, we're going to go by C-section. But if you develop herpes in your first or second trimester of pregnancy, then you're in trouble, okay? Then your baby's more likely to suffer from it. Illegal drugs, all of them are bad. Marijuana is still bad, okay? Call it legal, say it's okay in Colorado, it doesn't matter, it's still bad, okay? There's actually in Oregon, in the states where they have like medical marijuana, they're issuing pregnant women marijuana cards to fight with the nausea and vomiting. Okay, far more dangerous than Zofran. Okay, far more dangerous because they keep smoking marijuana right up until delivery, and it harms the neurologic development of the child. Okay, so yeah, they don't have they're not born with 3 arms and fingers out of the top of their head, but they're harmed. Okay, so marijuana is still bad. Caffeine, not so bad. The higher the dose, the more likely the risk of spontaneous abortion, and they usually will. They've traditionally said 200 milligrams a day is a safe amount of caffeine, but I believe your book actually says 600, which is like a lot. An average 8-ounce cup of coffee is 100. So 2 cups of coffee is fine. My amount of caffeine a day would not be, I would not have babies. Okay? I have far too much caffeine for me. Alcohol is bad, but we don't know how bad. And it goes back to that, how do you randomly study people to see what effect it's going to have? We don't, okay? And I always love to tell the story. In Italy, there was a big meeting of the World Health Organization, and they would talk about alcohol and pregnancy, and the general consensus was any amount of alcohol during pregnancy is bad for you, okay? Bad for baby, tends to cause fetal alcohol syndrome. And the Italians had to go, whoa, 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 whoa. We have wine at every meal. What are you talking about? Alcohol is bad for you. They don't, and the World Health Organization said, fine, let's do a study. Let's just, there may be something to being Mediterranean that protects you against fetal alcohol syndrome. I don't know. So they sent a research team into Italy, and they started doing the research, and they came back and they presented their findings that yes, Italians had like a 4-fold increased risk of fetal alcohol syndrome. And fetal alcohol syndrome has a very distinct facial features, like wide-set eyes and broad forehead and that kind of stuff. And when they started presenting the data, the Italians said, but that's how Italians look.
No.
They don't. That's how Italians with fetal alcohol syndrome looks, and it's so common that the fish didn't know they were wet. So yes, even Italians are at increased risk of fetal alcohol syndrome if they drink alcohol during pregnancy. Okay? But we don't know how much is too much. We don't know if 1 drink is too much, or if a drink every day is too much, or a 6-pack a day. We don't know, because every woman responds differently. It's not just the exposure to the teratogen, there's also the susceptibility to the teratogen. And that's where we don't know. And since we can't say there's a definite number, we just say, yeah, probably shouldn't touch it. Vitamin A we talked about is bad. Radiation, the all or nothing we talked about. Lead is bad, it harms the neurologic development of the baby. Pesticides, probably bad, especially during organogenesis. Depends on which pesticide it is, okay? And then toxoplasmosis, which is a parasite found in cat poop, okay? Bad for you, okay? If you're a woman who has always had cats in her life, always had outdoor cats in her life, you're already immune to toxoplasmosis, you're fine, okay? If you've always had indoor cats, cats get toxoplasmosis by killing birds and rats and eating them. Okay, if your cat was raised on Purina kitty litter, kitty towel, whatever, they probably didn't spend a lot of time eating birds and rats. Okay, so they probably don't have toxoplasmosis. You probably have never been exposed to it through that cat.
Okay, so
You see?
what
Now-
you're telling me is I gotta get rid of my cat when I get pregnant?
No, someone else has to take care of the cat poop.
Okay. That's it, I'm not getting pregnant then. Dexter ain't leaving.
Now he'll die sooner or later. So just don't replace him when he dies. That's fine. No. But you tell I'm not a pet person.
Right?
What?
You have all the kids.
I have kids, so I don't
No,
need
I gotta
pets.
have a kid in 5 years anyway, because I'm gonna peak at 26.
There you go.
You better get on
Popping out soon.
But anyway, the trick with toxoplasmosis is if somebody like you absolutely loves their cat, can't get rid of their cat, what do we do about it?
Have somebody else scoop the poop.
Have somebody else scoop the poop, or draw their blood to see if they're already immune to toxoplasmosis, see if they already have the IgG for toxoplasmosis and they're immune to it, that kind of thing. Okay, and that's where nurses really succeed, where we really excel, is teaching people how to overcome whatever difficulty they have in their life. I got a cat, I can't stand without the cat, and I'm pregnant, what am I going to do? The easy medical answer is get rid of the cat. Okay? But the nurses go, well, let's teach you a workaround and see if we can't make that better, right? Knowledge deficit related to toxoplasmosis exposure. But again, if your cat has always been an indoor cat, always eating good food, he doesn't have toxoplasmosis either. Because he only gets it from birds and rats, okay? Or birds and mice. They don't get it from kitty litter or kitty chow or whatever you feed cats.
What if they sneak out and eat cats and eat other?
There could be trouble.
cats?
That sure could be trouble. All right. Now, physiologic adaptations to pregnancy. I hired my son and he failed, so I had to fire him. I wanted a graphic of a superhero pregnant woman, okay? Going dun dun dun, you know, because from the moment the pea hits the stick, a woman is never the same again. She becomes a different species during pregnancy. Everything about your body changes the moment you are HCG positive, okay? And it starts to change, and it gets more and more pronounced as you get more and more pregnant, as you get closer to term, okay? And it's a very important concept to understand that right now, I don't think anybody in this room is pregnant, right? Okay? It is not possible to pass an 8-pound baby through your vagina. It's just not possible, okay? Now, vaginas are very small, babies are very big. And that's what freaks out a lot of women who have never been pregnant. How on earth am I going to get that out of that? The point is, what you have now, you wouldn't have 9 months after the pea hit the stick, okay? Because your body adapts and changes. And what was once a vagina becomes a birth canal, okay? And when you have a birth canal can handle an 8-pound baby. It's no big deal, okay? It's nothing. Anywhere from your body can't tell the difference between a 6-pound baby and a 9-pound baby. It is exactly the same to your birth canal, okay? Now, you get above 9, you start hitting those 10s, 11s. That's a little difficult, okay? No matter how big you are. But the 6, 7, 8-pound babies, it's all the same, okay? Because you change into Superwoman when you're pregnant. And I love the analogy of the Incredible Hulk if we could get rid of the big green monster part of it, okay? Wow. Bruce Banner is just a regular guy. Goes about his life doing his science-y stuff, right? But every once in a while there's an alien invasion or something, and he has to turn into the Incredible Hulk to accomplish this incredible thing. Jumping out of the sky and grabbing F-16s, whatever, right? And when he's all finished fighting off the alien invasion or crashing all the F-16s, he goes back to being Bruce Banner again. That is pregnancy. Right now, women are just women, just human beings like every other woman on the planet. But when the pea hits the stick, they start making that change to this incredible super being. And they become this amazing super being that is perfectly designed for the job at hand. And then they finish having a baby, and then they gradually return to normal woman again. Although they went from being a woman to being a mother. Slightly different, okay? So they're never the same as they were at 18. Lord knows we never get to be 18 again, okay? The older I get, the more I realize that, okay? Playing ultimate frisbee with the 9-year-olds yesterday was not a good idea. I was suffering the rest of the day, and I'm still suffering today. But such is life. So I never get to be 18 again, and you never get to be pre-pregnant ever again, okay? Once you have been pregnant, miscarriage, delivery, whatever, you're not the same person as you were before, okay? Both physically and emotionally. So, we'll start with the hormonal influences of pregnancy and why they happen. As we talked about, all the hormones come from the pituitary gland primarily, from the hypothalamus through the pituitary gland and then into the uterus and the ovaries and all that wonderful stuff. We talked about how the hormones influence ovarian follicular development, how they prompt ovulation, how they stimulate the uterine lining, how they cause the corpus luteum to grow and produce estrogen and progesterone. You are going to see estrogen growth, progesterone relaxation about 400 times during this lecture. If you don't walk away with that understanding, I can't help you. Okay. Estrogen growth, it's killing me. Hypertrophy and hyper, don't know. One is making the cells bigger, the other is making more cells.
Poly?
No, it's hyper something. Hypertrophy and hyper.
What?
One is making more cells, and one is making the cells you have bigger. Hyperplasia. That's the word, hyperplasia. Thank you. If I gave bonus points, you'd get a bonus point. So, but we don't get bonus points, so it doesn't matter. So, ovarian hormones. Follicle stimulating hormone, luteinizing hormone, maintains the endometrium, provides nutrition, aids in the implantation, decreases uterine contractility, and initiates breast ductal system development. Well, are you going to see a lot of FSH and LH in the 3rd trimester of pregnancy? No. See, all these things happen in the 1st trimester, right? Implantation, endometrial growth, that's all 1st trimester stuff, okay? So FSH and LH are early pregnancy hormones. They are from the pituitary gland, and they just help establish the pregnancy, okay? Reproductive changes. So the uterus is an amazing organ. It starts out about 2 to 3 centimeters high, like a small peach, and it turns into a watermelon. It grows 40-fold, something like that. It gets humongous compared to itself. It has the most potential space of anything in the body. Nothing else in your body can do what the uterus can do. It's an amazing organ, okay? And the interesting thing is that the growth patterns are very, very predictable. If you've ever had a bimanual pelvic exam and the provider has a hand in the vagina and a hand on the lower abdomen and he's measuring your uterus, okay? This is a uterus at 10 weeks. It's this big around, okay? We put our fingers on it and it's 10 weeks. This is 12 weeks. This is 14 weeks. Every single one of you, that's how your uterus grows. By 20 weeks, it's at the belly button. Okay? Very, very predictable pattern of growth. And that's why we measure fundal height in pregnancy. Because we can tell your gestational age roughly by measuring your uterus. Okay? There's not a lot of variation from woman to woman. Now, what you see on the outside, there's a lot of variation. Some people hold their uteruses in real tight. Some people they'll flop right out. They can do all kinds of stuff. And you say, oh, you're carrying high, you're carrying low. You're too small to be 30 weeks pregnant. You're too big to be 20 weeks. You hear that all the time. Okay, so it looks like there's a lot of variation. When we actually whip out the old measuring tape and measure them, every single woman is within 2 or 3 centimeters of where they should be. Okay, so it's a very predictable pattern of growth. Estrogen, progesterone. Estrogen causes hyperplasia and hypertrophy, and progesterone causes relaxation, allows the uterus to enlarge, to stretch, and not to contract too badly. Okay? Now, every single uterus starting at about 16 weeks begins having contractions. They're called Braxton Hicks contractions. We call them Braxton Hicks contractions so they don't freak you out, but a contraction is a contraction is a contraction. They're all exactly the same. Okay? It's just a tightening of the uterus, working out, getting ready. You can't run a marathon if you don't exercise. Okay? And your uterus can't labor if it doesn't grow. Okay? If it doesn't strengthen. And just like if I did 55-pound bench curls every day, my belly step would get bigger and bigger and bigger. Your uterus gets bigger and bigger and bigger the more it contracts and the more it fills. Okay? It's building up those muscle cells and it's creating more muscle cells. Okay? The uterus at term weighs about 2.5 pounds. And has a remarkable increased blood flow. The entire maternal circulating blood volume passes through the ovarian arteries every 6 minutes. Okay? That means if you blow out an ovarian artery, you bleed to death in less than 6 minutes. Okay? Very, very fast. And the uterus gets all the blood. Huge. Your blood volume goes up 50-fold, and 80% of it goes to your uterus. It's a huge increase. Which is why you can have such amazing blood loss in pregnancy, okay? Because there's a lot of blood flow going through there. The progesterone relaxes the vessels and allows more blood flow to the uterine vessels, okay? We talked about Braxton Hicks. Generally speaking, they're irregular. I don't like the phrase painless, okay? Sometimes they hurt, sometimes they don't hurt. But whether they're painless or painful has nothing to do with whether it's preterm labor or not preterm labor, okay? Because when we say that every woman has to feel pain in order to contract, then we discount all of those labor contractions that aren't painful. And I hear people all the time say, oh, I'm not contracting. No, but I get like hard every 3 minutes. Those are contractions.
You're lucky.
Yeah, you're just not feeling pain because you haven't recognized them as contractions yet. And you only feel pain when you recognize them as contractions because everyone said they're not contractions if they don't hurt. Okay? If I tell you that every day, if from the moment you're born, I say, don't ever move your right arm. Because if you move your right arm, it's going to hurt. Okay? You would stop moving your right arm before you turn 5. And it would hurt every time you moved your right arm. Because this is where everything comes from. Okay? The brain is an incredibly powerful thing. So I don't talk about contractions as painful. They are uncomfortable. Yes, with fatigue does come pain. If I do those 50 curls, sooner or later that biceps is going to burn, okay? But it doesn't burn when I move it. It burns when it's tired, okay? And so contractions are not necessarily painless or painful. But they prepare the uterine muscles for delivery. They're usually irregular. They usually last less than 60 seconds, but they can last for over 5 minutes. And those are called tetanic contractions. And they're usually not any rhythm to them. There's no predictable pattern to them. They just kind of happen, okay? But every woman who's pregnant experiences Braxton Hicks from about 16 to 20 weeks, whether they know it or not. What's really fun to do is when I have my centering groups, I'll say, how do you feel your contractions? And I ask every woman in the group, and every single one of them will describe it differently, okay? If I ask all of you who have been pregnant how you felt your Braxton Hicks contractions, you'd all have a different answer for how you felt them. Sometimes it's this band across here, sometimes it's band across here, band over here, my thighs hurt, you know, whatever. I get this tightening sensation, he just gets all balled up in one place. All of those are contractions, and I say anything between the nipples and the knees that hurts or tightens off and on, it's a contraction, okay? Ovarian changes, early on, the ovaries create that corpus luteum, and the corpus luteum can become a corpus luteal cyst, and your menses stop. Why do menses stop? Why don't you have periods while you're pregnant?
Because the uterus.
There are a lot of reasons. Let's start. Go ahead. Give me one.
I said the supply goes to the baby.
What supply?
The blood supply.
The blood supply? Not quite. Remember, when you have a period, you're not bleeding. You're sloughing endometrial tissue. Okay? So
And
since
the
you're...
uterus is what supports the baby and what continues to stretch.
It's the
over
endometrial
your-
tissue, right?
Right, so if you lose the layers, which is what your period essentially is losing layers of your uterus every month, then you wouldn't be able to sustain life for a baby.
Exactly. So you don't have the hormonal signal to stop the growth of the endometrial lining and sloughing. Okay? As your estrogen and progesterone levels rise, they support pregnancy. It's when they shut down that you have a period, right? And so that never happens. What other reason?
Because is it because the uterus is being used now?
Because the uterus is being used. It's all the resources are going to the placenta.
Isn't it like getting rid of?
Right, you're sloughing that endometrium, right. So the primary reason is that your placenta, your estrogen and progesterone levels rise to the point that they support the endometrial lining of the uterus. And there is no ischemia associated with it because there's no withdrawal of estrogen and progesterone during pregnancy. Okay? And then there was another one I was thinking of and it just disappeared, one right out of my head. All right, signs of the cervical changes. Chadwick sign and Goodell sign are the two most important ones. Chadwick sign, the cervix looks a little blue. And Goodell sign, the isthmus of the uterus, the lower uterine segment, gets very soft. Okay? And what's really neat, the book describes it getting soft like your earlobe. And I thought, oh, that's perfect. That is exactly what the
When I was
cervix
reading
feels
this
like.
book, I was like, because this is something like the tip of your
Yeah,
nose.
your cervix starts like this,
Yeah.
and it becomes like
I
this.
was like in the library doing this. I'm like, oh, that's really weird right
Yeah.
now.
Yep. And we teach people, like when I teach PAs and midwife students, how to assess the cervix. I talk about how soft it gets, and I talk about like feeling your hand and comparing it. But I'm going to use this and this from now on. That this is a soft cervix. Okay. Contractions. We use the face. Your contractions. That this is a mild contraction. It's a moderate contraction, and that's a strong contraction. And so your uterus feels like this when it's just barely contracting, like this when it's contracted pretty good, and like this when you're actively working on delivery. And you can literally knock on it. It's that hard. Okay? But it forms a mucus plug in the cervix to make a barrier from the outside world. And that mucus plug leads you to leukorrhea, which is a white discharge that pregnant women get. And that leukorrhea it tends to change the odor of vaginal secretions. And half of the women I know who get pregnant tell me they think they have a vaginal infection because they smell funny down there. And I say, well, do you smell fishy down there? No, not fishy, just unusual. And I say, yeah, that's because you're pregnant. Okay, it's leukorrhea. It's a very primal time of life. You're very close to all the other mammals when you're pregnant. All right, and so there's a leukorrhea, and it's a more pungent aroma. Not necessarily unpleasant, just different. Okay, musky, I guess, is a good description. Okay, but not fishy. Fishy is bad. Fishy is bad. The vagina is never supposed to smell like fish. If it smells like fish, go see a doctor. Okay, or a midwife. What?
Does he have like an STD when
Not an STD, well, it's
Like
bacterial
genetic-
vaginosis.
Okay, yeah.
Yeah.
And you can
If you have a a fishy odor when you exercise or have sex, that's bacterial vaginosis. Okay? All right, and then you call your provider if the discharge is bloody, green, foul odor, itching or pain, or you have itching in the vagina or pain in the vagina. Itching and pain is a yeast infection until proven otherwise. Foul, yellow and green is usually like a chlamydia or a gonorrhea, and blood, of course, could be any number of things. Okay. The vagina and the vulva continue to change in the second and third trimester. They get thick, and you start to see more prominent rugae inside the vagina. Remember the rugae being the folds in the vaginal walls. They become more thicker and they become more prominent. Again, this is allowing that vagina to become a birth canal. It's allowing it to stretch and get big enough to pass an napalm baby. So you have to create more potential space, more hypertrophy of the tissues. Okay? And of course, what causes hypertrophy and hyperplasia of the rugae?
Estrogen.
Estrogen, exactly. And what allows it to stretch and allow a baby to pass through?
Progesterone.
Progesterone, exactly. Okay?
So relaxin takes both of those and controls them lower down.
Relaxin?
Yes.
Relaxin is it runs hand in hand with progesterone,
Right.
and we're not 100% sure relaxin isn't progesterone. Your book makes it sound like they've already answered every question in the universe. They haven't. Where they haven't answered, they just make it up. Okay? That's the way medicine works, because we can't say, I don't know. All right? They're more susceptible to yeast infections? Yes. Why is the birth canal more susceptible to yeast infections than the vagina?
The birth canal?
Yeah, why?
Moist.
Well, it's definitely more basic, right? Or more acidic, right? Because the pH is dropping, so it's becoming more acidic. But a higher acid tends to fight against it, right? Does fight against infections. So what is it about pregnancy that makes the birth canal more susceptible to yeast infections? What is a yeast infection?
Bacteria.
What kind of infection is it? Not bacterial or viral. What category infection is it? You guys have heard the phrase opportunistic? Okay, it's an opportunistic infection. So where is the opportunity in pregnancy for a yeast infection? What happens to the immune system?
It's down, so you don't.
It's
kill the
down,
baby.
exactly. So the immune system decreases in pregnancy to prevent that graft versus host disease, which means you're more likely to get vaginal infections. Okay? So the same thing that enables you to stay pregnant really irritates the little sister, so to speak. Okay? And it's important to talk about vulvar hygiene and vaginal hygiene, to talk about this is normal. It's just more primal. There's leukorrhea, more discharge, remembering that the vagina is a mucous membrane, and that's okay. And also not to douche and not to mess with the vagina. Everybody should know that douching is bad for all women everywhere. Okay? If you douche or know somebody who douches, tell them to knock it off. Okay, because you're destroying the vaginal flora that naturally protects you when you douche, and you're more likely to get bacterial vaginosis, more likely to have vaginitis, more likely to have problems just because you're messing with something that ought to be messed with. Okay.
That's probably not how you're going to fix your problem anyway.
Exactly, you're not going to fix your problem. If you smell bad and you need a douche, you probably need some Flagyl. Okay? You probably have bacterial vaginosis. It's not that you smell bad.
Exactly.
Okay, now breast changes that occur. Breast changes occur. Remember, where is the first time that you read about what is it that initiates breast development in a pregnant woman? I said it like 2 or 3 slides ago. Where does that come from?
Oh, no. It's the gonadotropic, come on, guys. You guys know it. You guys know it. Quiet. I know you do.
Luteinizing.
Come on. The
All
gonad.
stimulating.
Come on.
Lactose.
Luteinizing hormone. Okay? The luteinizing hormone from the ovaries, 8 to 10 weeks of pregnancy, stimulate duct development in the breast. So your breasts begin changing at 8 weeks in pregnancy. Okay? And it is measurable and visible usually before 16 weeks. Okay? And that's what they call lactogenesis. Anybody who's ever been pregnant, what's one of the symptoms you figure out what you know you're pregnant? Because your breasts get tender and firm, right? They change because that LH stimulates the breast, okay? So breast development begins in the very first trimester, and lactogenesis 1 begins at about 16 to 20 weeks. Lactogenesis 1 is the differentiation of the lactocyte and the beginning of the function of the lactocyte. Whenever people say, my milk came in, your milk comes in when you're 16 weeks pregnant. That's when your breasts start making milk, okay? But the Montgomery tubercles begin to function. They begin to release that lubricant. The areola get very dark in pigmentation thanks to melanotropin, and the lactocytes begin secreting a pre-colostrum, and it's like a clearish, kind of slippery discharge. And if you mess with the breasts of a pregnant woman, they're always doing it. My nipples started leaking, and I'm only 28 weeks pregnant. Perfect. That tells you it's working. Okay. So when you get breast development in the first trimester and again in the third trimester, they leak breast milk during the pregnancy, you know the breasts work. Okay. That's like saying I hear a heartbeat, so I know your heart works. Okay. And then lactogenesis 2 begins 36 to 72 hours postpartum, and that's when people say, my milk came in, okay? It was always there, okay? It just kicks into hyperdrive after the baby is born, okay? And what causes it to kick into hyperdrive? A drop in progesterone. Because remember, progesterone has been kind of calming everything down, keeping the breast at bay, going, just wait a minute, just one more week. Okay, and then the placenta goes, and the progesterone level drops, and the breasts go, I'm free! And they kick into high gear, and you get lactogenesis 2. Okay? So, it is very common when lactogenesis 2 begins to have a little physiologic engorgement, and that's a fullness, a hot feeling in the first 72 hours after the baby is born. And people say, oh, I'm engorged, pump. There's not a lot of breast milk in there. You can't pump it out, okay? That's not breast milk that's in there. That's blood and body fluids and all the other things that are building the breast, okay? That's all the setup. All pumping does is make your nipples sore and make you wish you hadn't pumped, okay? It doesn't help. But it's kind of like this big wave crashes on the breast, and when it comes away, the physiologic engorgement goes away, and it leaves behind your breast milk, your mature breast milk. From colostrum to mature breast milk, we'll talk about it later. And then you have to know when you're talking to pregnant women that their bras are going to change in size. The average pregnant woman gains a cup size in the first trimester and another cup size in the third trimester, and then they vary between 2 cup sizes after when they're breastfeeding. When they're full, they're usually 2 cup sizes bigger. When they're empty, they're 2 cup sizes lesser, and they usually kind of hang out in the middle by about 3 months postpartum. What can I say? The breasts aren't here to sell beer. The breasts are here to feed babies. And they work very, very well at it. Okay, integumentary system changes. These are fascinating. And it's all hyperpigmentation thanks to that melanotropin. Okay, it forms cloasma. What's cloasma? It's the mask of pregnancy. Okay, you get like a butterfly darkening right in here on your cheeks. All right. And cloasma comes from hyperpigmentation, comes from the melanotropin. That's what makes it happen. But it happens so baby can see your face better. Okay? Because your eyes and your cheeks differentiate and baby can see your face. Okay? Babies focus on the color change from dark to light. That's what they see. That's why all newborn toys have black and white triangles and squares on them, so they can see them better, okay? And so babies focus on the drastic color change in mommy's skin, which is why they get the linea nigra, why they get dark nipples, and why they get dark cheeks and pale eyes, or dark eyes and pale cheeks. I find that the darker skinned women have darker eyes and brighter cheeks, and lighter skinned women have darker cheeks and brighter eyes. But there's always a contrast between the cheeks and the eyes when you're pregnant. And you can see pregnant women. I walk around the mall with my kids and I'll be like, pregnant, not pregnant, pregnant, not pregnant. Because you can see it, okay? The face, it's written all over your face when you're pregnant. Okay? Yep. And then the areola darken. And another thing that darkens is the palms. Your palms get very dark and red while you're pregnant as well. Okay? So you'll see there's a stria gravidarum, you get these angiomas, pulmar erythema, and that's a twofold. One is the darkening of all the other skin, right? But also, it's the increased blood volume that comes along with pregnancy. All that blood's got to go somewhere, okay? And it's going to push out to the extremities whenever it can, okay? And then sometimes that pulmar, or the blood in the extremities kind of stretches on the skin, and it causes an awful lot of pruritus, especially in the belly. Pregnant women are always doing this, okay, because it just itches, all right? And that's fine, and it can turn into this disease called PUPS, which is pruritic urticarial pustules in pregnancy. Yeah, pruritic and urticarial pustules in pregnancy. And it's just an itchy skin while you're pregnant. It'll go away once the placenta leaves the body. It's not a big deal, but it sure is annoying. All right, neurologic changes. There's a decreased attention span, and I always describe it like a man with an erection, okay? When a man gets an erection, he can't think, right? As soon as he gets hard, nothing else matters, right? Because all the blood has left his brain, and it goes to his penis, okay? And he thinks with his penis once it gets hard. The same thing happens in pregnant women. All the blood leaves the brain, and it goes to the uterus, okay? And it makes it hard to form those synapses. Okay? What's really happening is your whole life is changing. Everything is different. And you got a lot of things to work through. You got a lot of adaptations to make in order to become a mother. And when you're doing that, your brain gets distracted and it focuses on other places. But they have trouble with attention span, concentration, memory. They suffer a lot of that. And they're always like, I got pregnancy brain. Sure do. Because you got more important things to think about than whether or not you put the garbage cans out last night. Okay? More important things than did I start the laundry yesterday. Those things aren't important anymore. Now they're focusing on what's really important, and that is their transition to motherhood. Okay? Carpal tunnel syndrome, very common neurologic change. Remember I talked about all that blood's got to go somewhere, and it tends to put pressure in the joints, in the wrists, in the elbows, in the armpits. And whenever you have swelling and edema in a joint, you press on the nerves that pass through that joint, and you tend to get numbness and tingling further on beyond that pressure. Okay? Carpal tunnel, very, very common. And they talk about it just as in the hands, but it's really in every limb. Okay? Syncope. Believe it or not, it is not uncommon for pregnant women to pass out. And every time a pregnant woman passes out, I was like, oh my God, she passed out. It's okay. Okay? It wasn't very long ago in American history, whenever you'd scare a woman, you go, boo! Ah! And they have what's called hysterical sympathy, or a syncope. And that's okay. It's not a big deal. The trick is when they pass out, you make sure they don't hit the ground too hard, and you're all right. But what normally happens when they have the syncope in pregnancy is they talk about, I was just driving along, and I got really hot all over, and I pulled over, and I passed out for a couple seconds. Yep, that happens all the time. It's okay. It's not a big deal. It's very, very rarely is it ever heart failure, dysrhythmia, all the other things that can cause syncope. Okay, because understand, you have to be pretty healthy to get pregnant, right? If you're sick, if you got heart failure, you got something that's causing you to pass out all the time, you're not getting pregnant anyway. All right, so it's a pretty safe time. It's a pretty safe time in women, and these things that freak everybody out, but they're very, very okay. We run tests. Most of the time, it's a little anemia or low blood sugar, something like that. But syncope is very common. Okay, changes in sleep pattern. Your book talks about them as disturbances in sleep pattern. It's not a disturbance. It's a change. It's an adaptation. It's not something wrong. It's something right. It's something physiologic. Because do babies sleep for 8 hours a night? Absolutely not. So can mommy sleep for 8 hours a night? Absolutely not. And so the other part about that is, when do mammals have babies? Noon or midnight? Midnight. If you've ever had a pregnant dog or a cat or a cow or a horse, you will find that they're pregnant one day, they disappear, and you find them with a litter of kittens the next day. Okay? Because all mammals are born at night. And so nighttime so pregnancy is a very nocturnal experience for women. And they find from dinner to breakfast that they have a hard time sleeping. Oh, they can sleep during the day like mad. They have plenty, 8, 12 hours of sleep during the day, no problem. But boy, the sun goes down and they are wide awake. Okay? And they tend to fall asleep around 2 or 3 in the morning, sleep for a couple hours, and then get up and face the day. And so what we tell people is, it's not a disturbance in your sleep pattern. It's an adaptation in your sleep pattern. You're supposed to sleep during the day when you're pregnant. You're supposed to be tired because mommies are up at night, because babies are up at night. So we encourage napping during the day and sleeping at night. Okay? Works so much better. And people always say, but if I nap during the day, I'll never get to sleep. Don't worry, you won't get to sleep anyway. Pregnant women, especially laboring women, have the amazing ability, they can be awake for 5 straight days and not hallucinate. It's an amazing trick. Talk about your superpowers. I couldn't do that. 48 hours, I'd be seeing flying cows and stuff. I'd be hallucinating, and so would you, okay? But get pregnant and start laboring. You don't sleep in labor. You don't, okay? And they just keep right on trucking because they're superhuman and they don't stop. And they get less and less sleep the 5 days before the baby's born, and that's on purpose, okay? All right, cardiovascular changes. Understand that the heart has to work really hard, right? Your blood volume is going to go up dramatically, and your heart has got to compensate for it. Also understand that there is no empty space in your body right now, right? So where do you find the room to put a 40-week infant in your body? Everything has to be pushed up out of the way, right? It goes out and it goes up. So what used to be all the intestines, the pancreas, the liver, everything gets pushed up into the diaphragm. The diaphragm gets pushed up into the lungs. The lungs get pushed up, out, and over into the heart, and the heart gets pushed up, okay? It all comes up here, all the important stuff, okay? And so the heart gets pushed upward and to the left, and it starts to hypertrophy because of the increased blood volume and the increased cardiac output. The heart sounds tend to spring leaks in the heart all the time. You get these exaggerated first and third sounds, and you get systolic murmurs. Something like 80% of pregnant women will develop a systolic murmur during pregnancy. Okay? They tend to get palpitations. Palpitations happen because the heart's being squeezed, and the heart's a horrible neighbor, so it gets irritated, and it starts to do those misfires, and you get palpitations. And I was like, I get this flutter in my chest. I'm like, it's okay. You're just pregnant. It's fine. It's an adaptation. It's fine. It's not going to hurt you. When it gets really bad and it causes them to pass out every day and they can't function, we'll send them to the cardiologist and let them do a 24-hour Holter monitor, and they'll come back perfectly normal, and we'll say, I told you so, and we move on, because it's just an adaptation of pregnancy. It's very, very unlikely that they actually develop heart disease during pregnancy. Possible, not common. And they get lots of signs of poor circulation, okay? Lots of swelling in dependent places, lots of varicose veins, that kind of thing. And it's just because their blood volume has expanded so much, and progesterone relaxes all the blood vessels, and everything kind of blah, and they just kind of sit there and become dependent. Okay? The blood, not the person. All right. So there's a dramatic increase in blood volume, 40 to 50% increase from 6 quarts to 9 quarts. It's a huge change. Okay? Most of it is in plasma and erythrocyte volume. It's not necessarily all the cells, it's just it's mostly plasma. They have an increased need for iron and physiologic anemia, and that's because if you have 5 fish in a gallon bucket, it looks like 5 fish in a gallon bucket. You take that same 5 fish and put it in a 40-gallon bucket, it looks like you don't have very many fish, right? Same thing with this. They're not actually anemic, it's just they have so much plasma volume that it looks like they don't have very much iron. Okay? So their total iron binding capacity doesn't change, their total iron count doesn't really change, but they become anemic because they don't have enough red blood cells to support the amount of plasma that they have. Okay? And so we tend to give them iron supplements to alter that red blood cell count a little bit. There's an increased blood flow to the uterus, the kidneys, and the skin, and that means that all of them work really well. Okay? The uterus, the kidneys work like crazy, the skin works like crazy, they sweat a lot, they pee a lot, that's okay, all right? It's because of that increased blood flow. And so we want to talk about adequate hydration and diet, especially using protein and iron. Why protein? Because proteins build, right? And what are they doing but building another human body? So they need a nice high protein diet. And they need iron to support that physiologic anemia. And interestingly enough, they have very high fibrinogen. Okay? Again, fibrinogen is a building block of the body, so the fibrinogen count goes up. But what else does fibrinogen do? It increases your risk of blood clot. Okay? Changes in blood components. The leukocytes tend to rise a little bit. In normal pregnancy, normal leukocyte count is what, between 9 and 13? Something like that, right? Is it? You guys do adult health more than I do? In pregnant women, it's closer to 15. Laboring women can go as high as 25,000, and it doesn't mean anything. It's normal, okay? Part of it is the strain that pregnancy causes on the body causes a response in the leukocytes. But the leukocytes don't work very well, which is why they have this decreased immune function despite having this increased leukocyte production. So you make more white blood cells, they just don't work as good, okay? Albumin decreases, hemoglobin decreases, fibrinogen increases by 50%, along with your factors 7, 8, 9, and 10, which increases your risk of blood clots because it makes you more hypercoagulable. Okay? And so anytime, any pregnant woman, we have to talk about risk of DVTs. We have to talk about travel precautions if they're going anywhere. Okay? Blood clots are very high in pregnancy. About I think it's like 1 in 1,500 pregnant women will get a blood clot. That's a lot. Okay? The immune system. There's decreased leukocyte function and a depressed immune system function, which is really cool if you have an autoimmune disease like arthritis and lupus and asthma and those kind of things, because they tend to do well during pregnancy. Because the immune system is attacking you during an autoimmune function or an autoimmune disease, and it kind of slows down a little bit. Not always. They do have flare-ups. They struggle. But as a general rule, women with autoimmune disorders enjoy being pregnant because they don't have very many problems. Okay? Again, we have to watch out for our sources of infection when we're pregnant. Avoiding large crowds, stay away from kids with red spots all over their faces, that kind of stuff. Don't eat raw food and get your food poisoning because you just can't fight back. Take your flu shot. Stay away from people who have fevers. We have to remember that they have problems with their immune system. They're just a little bit weaker and more susceptible. Okay? Interestingly enough, immunoglobulin production doesn't change. Okay? But it appears to change because half of it goes to the baby. So she's giving away her immunoglobulins to the baby, so it looks like her circulating volume is low, but it's really not. Okay? There's only one immunoglobulin that passes the placenta, and it's IgG. You go, girl. IgG, you pass the placenta. Okay? The other immunoglobulins do not. All right? Cardiac output. We talked about a 30 to 50% increase. And the blood pressure is really fascinating in pregnancy because it undulates. Okay? It starts with a nice high blood pressure, a slight rise in the beginning of the first trimester. Then it slows down and it dips a little in the second trimester, usually about 10 to 15 points from where it normally is. And then right around 28 weeks it starts to rise again, and it continues to rise all the way through pregnancy. Okay? So it's that undulating blood pressure that protects you against preeclampsia early on, but sets you up for preeclampsia the later you get in your pregnancy. And it's why we can survive blood pressure changes in pregnancy, because it usually doesn't become a big problem until like 38, 39 weeks. It's only a problem when it happens early. But just know that there's an undulating blood pressure. Okay? And it's why women with syncope are going to pass out more in the second trimester than the third trimester, because their blood pressure drops a little. Okay? You get stasis of blood in the lower extremities, you get varicose veins, you get blood clots, and you get hemorrhoids like crazy. Thank you, progesterone, for loosening everything up for me, right?
You have a history of venous thrombosis before you're pregnant? Are you more likely to get them when you're pregnant?
Yep. We tend to put those women on heparin, or at the very least aspirin, during their pregnancy. And then we switch them to, I think we put them on Lovenox and we switch them to heparin. I think that's what it is. We switch them to heparin for like a week, and then we deliver them, and then we put them back on Lovenox again. Because yes, they're very likely to get blood clots in pregnancy. If they've had them before, if their mother's had them before, if there's a history of DVT in the family, we get very anxious about blood clots. Okay? There's let's see here. So what sets us up for the blood clots? What are the things that I've talked about that have increased our risk for blood clots? Fibrinogen goes up, right? Estrogen goes up. We know estrogen's a risk factor. What else? What? The blood volume is not such a big problem, but it's the fact that the blood volume causes stasis, okay? Is that there's more blood and not a lot of pressure to get it back to the heart, okay? And so it's that stasis, high fibrinogen, high estrogen, sets us up for blood clots, okay? And so we encourage daily walks to enhance circulation and improve peristalsis. Yeah. All right. Supine hypertension syndrome. Extremely common in pregnancy. If you have a pregnant woman lay on her back for more than a minute or two, she's going to get she's going to complain a lot. Okay? And what's really interesting, and now why does that happen?
Oh, the pressure on the
Because it's on the beat.
Because there's pressure on the vena cava, right? Pressure of the uterus weighs 2.2 pounds. The baby weighs 8 pounds. The amniotic fluid weighs another 2 pounds because it's about a liter. Okay? And then there's all the increase in blood flow. 50% increase in plasma volume is another 3 liters of blood. That's another 7 or 8 pounds, right? And all of that weight at the same time sits right on the vena cava. and it compresses the vena cava, which decreases blood flow to the heart, which makes the heart say, oh my God, hypovolemic, quick, tighten everything up. And what does it do? It shunts all the blood away from the uterus, and it makes mom kind of pass out and then recover again. Okay? And what's really neat is they're going to vomit when they do that. All right? And what happens is they're laying on their back, and all of a sudden they get this supine hypertension, and they go, bah! And what did they do? They got off their back. Isn't that the coolest thing ever? I just love it that the body protects itself. Okay? Who came up with that plan? Because you can't vomit on your back, so it forces you off your back. How cool is that? Boy, I tell you, the more I study the body, the more I'm like, oh yeah, someone was thinking. There's a lot of logic that went into that. That's not just dumb luck. Okay? So know that it's going to happen. They're going to get sweaty. They're going to get pale. They're going to get dizzy. They're going to vomit. So we want to keep people off their back. Even when they're in labor, you want to keep them off their back. I always tease that, the whole pregnancy we say, never, never, never lay on your back. You go into labor, we tie you to the bed and put you out flat on your back and say, don't move. They're still pregnant, even in labor. Okay? So we want to get them off their back. Right? The other thing that's important is they get this orthostatic hypotension. So remember, if they stand up too quickly, they're going to pass out. If they're standing in a hot shower or sitting in a jacuzzi, they're going to have troubles. Okay? Just like old people. How many times have I mentioned relaxation of the peripheral vessels? Thank you for that progesterone. Everything is relaxed. Okay? So you've got this relaxed vessels, you've got this increased cardiac output, you got increased blood volume that sets you up for all those wonderful vascular changes in the lower extremities, okay? So varicose veins are very common. Varicose veins that run all the way up the leg and into the vulva are extremely common. Vulvar varicosities are very common, very painful. Hemorrhoids, if there's a weakness in your body, pregnancy will find it, okay? Because everything dilates and extends and works real hard. Okay? Respiratory system changes. There is an increased tidal volume thanks to estrogen causing hyperplasia of the lung tissue and progesterone causing relaxation of the bronchial smooth muscles. So they get bigger, better bronchial or lung tissue and wide open bronchioles that allow air to move in really easy. That being said, good old uterus and everything that used to be in the abdomen is now pushing up in the lungs. And you will always hear pregnant women talk about, oh, it's hard to breathe. Oh, especially that second trimester. Boy, from 20 to 28 weeks, they kind of, I have to, it's not like I'm suffering, but I have to really concentrate on breathing. Yup. Okay? Very, very common to have a little problem with that. Because the diaphragm elevates and it's hard to go. And what happens is, as you get more pregnant, they develop this barrel chest and the lungs expand outward instead of downward. And then once that barrel chest develops and the lungs open up, then the difficulty breathing gets a whole lot easier. And then, good old 36 weeks or so happens and the baby drops in the pelvis, okay? And when the baby drops in the pelvis, what happens up here? All of a sudden the lungs can expand again. So 36 weeks, 38 weeks, moms experience this phenomenon called lightning. And they're like, oh, I feel amazing. And it's not lightning like a bolt of lightning. It's lightening. Everything is lighter now. Okay? Ears, nose, and throat. Yes, the eyes change. Don't tell a pregnant woman to go see her doctor if she gets blurry vision. It's normal. She doesn't need a new prescription, okay? Just wait. It'll go away. Spend money on glasses. You'll have to replace them again when you're not pregnant because it increased intraocular pressure relaxes the eyes and opens them up and changes the shape of your eyes. And your prescription will change while you're pregnant. It's important to know it and not worry about it, okay? Nasal stuffiness and congestion in the nose. Remember, all that blood's got to go somewhere. And the same thing that makes your feet and your hands swell makes your face swell. And so pregnant women get a lot of nasal congestion in the second trimester or third trimester. And they're always going to be telling, I can't breathe. I need something. And I'm like, yeah, wear breathe right strips. But none of the over-the-counter cold medicines are going to work because she doesn't have mucus production. She has hyperplasia of the tissues and fluid making everything tighter. So it's not mucus that's the problem, and no decongestant is going to work. I tell them to wear breathe right strips and warm humidified air. And that'll open up their sinuses and give them more room. Okay? GI tract. Again, Estrogen causes hyperplasia, progesterone causes relaxation, right? So they get hypertrophy of the gums. They can have these epilodes will form in the gums, and big old masses will form in the gums, and they'll go away later. But they're annoying as heck. Okay, they tend to get talism. What is talism?
Where is it?
Second word, gingivitis and talism.
Excessive saliva production.
Exactly, spitting. They're always carry around a little spittoon and spit into it all the time. Okay, they just get this excessive saliva and they have to spit an awful lot. Okay. And then because of the relaxation in the esophagus, they get reflux, they get heartburn, and that's all perfectly acceptable. Okay? And then in the stomach and small intestines, they get morning sickness, which causes some problems with keeping food down. It tends to be very closely related to high HCG and altered thyroid production. Okay? Those two hormones right there, the HCG and the TSH, will cause an awful lot of hyperemesis. If it's not that, it's psychosomatic. Okay? An awful lot of the more type A personality you are, the more hyperemesis you have in the first trimester of pregnancy. Okay? And hyperemesis gravidarum is almost exclusively a disease of the Western world. Okay? There is no hyperemesis gravidarum in Somalia, which is interesting. Okay? The further you get away from developed nations, the less hyperemesis becomes a problem. Okay? It is there because of the HCG and the thyroid. That happens all over the place. But the psychosomatic component is Western European and American. Oh, I got in so much trouble in midwifery school because I did a presentation on the psychosomatic associations of hyperemesis in pregnancy. And I had this one professor who just ate my lunch on that one. And it's just like, I take offense that a man would say. And I was like, I didn't say it, it's great. I got 16 randomized controlled trials. It's not me, it's this. But you shouldn't point it out. Whatever. I'll take that C with pride. The lower GI tract, again, good old progesterone slows everything down. Constipation is very common. And so we increase our fluids, increase our fiber, take our stool softeners, and remember that the more time you spend on the toilet, the more likely you are to get hemorrhoids. Okay? The gallbladder and the liver also slows down. And we have an inefficient function in the gallbladder. Very common to get right upper quadrant pain associated with the gallbladder. Be it cholestasis, inflammation of it, or cholecystitis, or plain old blockage of the gallbladder. Okay? Very common in pregnancy, and nothing you can do about it. Just write it out, it'll be okay. If the gallbladder actually fails or gets completely obstructed, we can cut the gallbladder out, but we try real hard not to. Okay? Because it's hard to go through the belly button when there's a uterus in the way. Right? Urinary system. Remember we talked about the increased blood flow? That's going to affect the kidneys, okay? They're going to get more blood flow, which is going to get more function. They're going to have a higher glomerular filtration rate, okay? But they lose the ability to function because the muscle movements that make the ureters, stay tight and continue to push the fluid, the urine down into the bladder, those go away. And so they get a lot of stasis in the ureters, they get a lot of reflux from the bladder into the kidney, and so they have this increased function, but they just can't get it out well enough. And so they're more likely to get kidney infections, and a kidney infection during pregnancy, pyelonephritis, can be lethal, okay? Very, very dangerous. Pregnant woman complains of flank pain, you thump them on the back when they complain of flank pain, and they jump up like, oh, what was that? Admit them to the hospital, they need 7 days of antibiotics, okay? So that urinary UTIs are extremely common, and a significant portion of UTIs are going to bump up into the kidney and cause those infections. Okay? We're almost there. Endocrine system. The thyroid gland causes an increase of T4. And why is there an increased thyroid production during pregnancy? Remember the thyrotropic hormones from the hypothalamus? Right? Good stuff. So there's an increased T4, but not an increase in the free T4. It's used more. Okay? And the metabolic rate increases up to 25% by the term. So pregnant women always complain about how hot they are. They sweat easy and it's hot all the time. And they talk about having this big baby that's causing all this heat. It's because their metabolic rate is increasing. And the metabolic rate is increasing, of course, to support the baby's increased needs. right? All right. And the pituitary gland is where we get our prolactin, oxytocin, and vasopressin. We all know that. Adrenal glands. Oh, good Lord, will this lecture ever end? No, I'm kidding.
We can end it.
Oh, we got to
9
get
more
through.
slides.
We don't have to. I'm not taking the test. So the adrenal glands are going to cause, they're going to have an increase of cortisol. And why is there an increased cortisol in pregnancy? Because what does cortisol do? Stress response, right? So we're putting the body through its paces. We're going to have more cortisol, okay? And an increase in aldosterone. The aldosterone works on the renal system to enhance fluid retention and to enhance sodium retention, right? So we need those because the body is using up all this stuff. So we need to increase our sodium retention. The pancreas, I thought it was really funny. As big a problem as gestational diabetes is, there's like 4 sentences on the function of the pancreas during pregnancy, okay? But the beta cells in the pancreas increase in number and size, hypertrophy and hyperplasia, and that causes an alteration in metabolic function for our carbohydrate metabolism. During pregnancy, the cells actually become insulin resistant, okay? It's not that the pancreas can't keep up. It's working, it's increased function during pregnancy. But even the increased function sometimes can't overcome the insulin resistance in pregnancy. As an example of how insulin resistant women become during pregnancy, what's the average dose of regular insulin if you're using regular NPH in a diabetic person? What's the average? How many units would you give? You guys know? Anyone ever worked with a sliding scale before? And you give like 2 units to drop the blood sugar 50 points, right? Okay, and the most sliding scales are like 2 units for every 30 to 50 points, okay? And so the average person takes like 4 units of regular and 8 units of NPH, okay? Pregnant women, I've seen them take more than 100 units of insulin to have to give themselves 2 shots with their insulin syringe because they need more than 100 units in order to keep their blood sugar in control, okay? It gets ridiculous. They become extremely resistant to insulin or to glucose. And that's why they get diabetes, they get gestational diabetes, because they get this incredible insulin resistance. It helps support the growing pregnancy, but it doesn't, the pancreas can't keep up, okay? Women who get gestational diabetes while they're pregnant have a 25% increased risk of diabetes, or I'm sorry, a 25% risk of diabetes for the rest of their life. And woman who has gestational diabetes needs an annual glucose screen to rule out diabetes every year, forever. Okay? We'll talk about it more when we get into high-risk labor and delivery, or high-risk pregnancy. Musculoskeletal changes. We talked about this a little bit before. Pregnant women are the only mammals that can stand up straight when they're pregnant. Every other mammal goes back on all fours. Okay? Humans are the only ones that can stand up straight, but they don't quite stand up straight, right? We get that pregnancy gait as the center of gravity shifts back and down, and then the legs go out, and they get this. And it's a wonderful walk. It really is. And I love it, too, because it swings baby and rocks them nice and gently as they walk through. I'm like, oh, look at the baby rocking in his mommy's pelvis. It's perfect. Okay? And again, they have difficulty with calcitonin. They have an increased calcitonin, which suppresses bone reabsorption, which makes for nice, strong, healthy bones, but it means lower calcium. And so we need to enhance their calcium just a little bit while they're pregnant. Okay? And leg cramps, incredibly common in pregnancy. So a little daily stretching and a little exercise will help with those leg cramps a little bit. As an interesting alternative treatment, a bar of Dove soap placed in the sheets down by her feet will make her leg cramps go away too.
I've heard about that.
Yeah.
I've heard that helps
For-
versus legs.
Yeah, it sure does.
My mom does that. She
Yep.
swears by it. I'm like, it's psychological.
No, it happens all the time, and I don't know why. We haven't figured out why. A bar of Dove soap in the sheets at the foot of the bed decreases your restless leg and decreases your leg problems in pregnancy.
See, I feel like
It's just pregnancy?
Yep. Yeah. Well, it helps with restless leg syndrome when you're not pregnant, but pregnant women get restless leg syndrome during the pregnancy, so it helps with that too. You just put it in the sheets. I recommend taking it out of the box. Just throw the bar of soap and put that right on your feet. And we don't know why. Just like we don't know why cabbage leaves help engorgement. We know they do, but we don't know why. Okay? Back before the Civil War, American slaves learned that if they eat the fungus that comes off of cow manure, that they fought infection. We didn't know why, but we later found out, thanks to Alexander Fleming, that that was penicillin that they were eating. Who knows what we're going to find when we break down bar? What is in Dove soap? There's something in it. I don't know.
That's kind of scary.
What? What's?
That's maybe cure.
Doesn't cure, just decreases the symptoms. Yep. All right. So we need a comprehensive health and physical exam and ongoing education all the way through. And then lastly, we got to talk a little bit about psychological changes. Remember, everything changes. You go from being woman to being mother, and that is a huge adaptation. Okay? Same thing for dads, same thing for grandparents. Everybody has to change. And so we have to recognize that. And since we're out of time, I'll leave you guys to read about Duval and Rave. I'm sorry, not Rave. Duval and, what was her name? Rubin. Thank you. Duval and Rubin are two theories of maternal transition and how they reorient their lives to focus. It starts off very self-centered, very self-focused. As the baby grows, they start to realize that baby is actually another human being, and then they have to reorganize everything. And so where they used to only have to live for themselves as a couple, now they have to live for the family, and everything changes. And the desire to go out to the bars go away, and the desire to go hang out at clubs, whatever, starts to go away. And you find yourself curling up with a good book instead of going out to a club. And it's part of it is maturity. We don't play as much as old people as we did when we were kids. But the other part is that our focus has shifted from our own personal enjoyment to that of what's necessary for the family, or our family's enjoyment. And we start to get enjoyment by watching our children succeed, enjoyment by watching our children grow and learn and that kind of thing. So it shifts from an internal focus to an external focus. Okay? All right. So a few extra slides on that one. We don't have to talk too much about it. And I'll let you guys go. All right? Questions, needs, wants, concerns, anything else? Oh, your annotated bibliography.